Hey guys, this is Charles Clinton, Chapter 20, Coronary Angiography and Intravascular Imaging, Braunwald's Heart Disease 11th edition. This is part 5 of these summaries. Here are my disclaimers, so read them through. This is on the go, no editing. If this helps you out, I'm happy for you. These are the standard angiographic projections. So here we can see what each of the different projections we've talked about on the previous summaries see in the angiography lab. So you can pause the video and watch this through. This is pretty hard. Don't think it's a good idea memorizing it, because if you don't understand it, you will forget it pretty soon. Then we are more focused on you understanding the main concepts. That's why last summary was based on understanding the projections and orientations. Okay, so in this figure you have the LAO on the left with the corresponding angiography image, and the RAO on the right with the corresponding angiography image. Both of these you could make caudal or cranial, and that's why you see very slight variations on them. So there's a couple of rules. One rule, for example, is that caudal has the letter U in it. Then remember that caudal is great for seeing all the circumflex in its entirety, its different portions. So look at LAO and RAO caudal. You can see that in both you can see the circumflex pretty well. While in the cranial has the letter A, as in left anterior, the letter A, anterior descending. So look at LAO and RAO cranial, where the LAD in almost all its extension is seen. Also remember what we talked about the projections with the form of the heart, that with LAO the form of the heart was quite circular, and it's mainly like this in this projection on LAO and in general. And in RAO, remember we talked about the heart looking at like a cone pointing towards the towards the right if you're looking at the image, or if you're the patient towards the left, of course. So those are a couple of interesting things to take into account. This mnemonic, I made it looking for a way to differentiate LAO from RAO. I thought that it's easier to see the spine in the LAO projections in general. Look at the LAO here and look at the spine. You can see it in both caudal and cranial. While in the RAO, it's harder. It's harder to distinguish the spine. But these illustrations may be a little difficult to interpret because you cannot see the whole image that we see in the cath lab. So these are some of the different things to take into account. This is for the right. We already talked about left coronary. Now let's talk about right coronary artery. Okay, this is a mnemonic. It's in Spanish. So it says Clinton de lado por el rao. This basically means we're talking about ex-President Clinton, not me. Clinton by the side through the backside. And then what does this mean? You can associate the C and the L with L and the R. The CL in Clinton goes with LAO and RAO. C with an L and L with an R. How can you see this in the angiography? Okay, look at what am I talking about? I'm talking about the disposition of the right coronary artery. how the right coronary looks depending on LAO or RAO. So in LAO, it looks like a C, pretty clear, either cranial or caudal, while in the other one, in the RAO, the right coronary looks like an L, or at least not like a C. Its curves look more acute angle curved. So C with an L and L with an R. Okay, now about coronary anatomy. There might be a third branch originating from the left main. That's called the ramus intermedius or intermedius rami, and this happens in 15% of the population. It is usually attributed to the circumflex artery. The LAD artery provides circulation to the anterior anterolateral wall of the left ventricle with diagonal vessels and the anterior 2/3 of the interventricular septum with septal branches. We have different types of left anterior descending, type 1, 2, and 3. 1 means that it doesn't reach the apex, 2 reaches the apex, and 3 wraps around the apex. Okay, then the one that would be associated probably with a dominant left circulation would probably be, and well, it depends, because we don't also have the circumflex, so better not make this association. Another website I would recommend you is for the principles in angiography would be cardiologysite.com. It has a lot of examples of angiographies which you could practice with. Now moving on to the circumflex artery. It courses along the left AV groove and provides branches to the left atrium, sinoatrial branch 40% of cases, and left ventricular lateral and posterior walls with branches called obtuse marginals. They're called obtuse marginals due to the angle we have on that side of the heart. It's obtuse. It's not that acute. That's why it's called obtuse marginal, and it's marginal because it's in the margin. So now the right coronary artery, it gives off atrial branches. The SA node is mainly perfused by the right coronary in 60% of cases. It gives off the branch to the conus, has to do with the right ventricular outflow tract. It gives off the acute marginal branch. That's why on the right the margin has a more acute angle. That's why it's called acute marginal branch. It continues to the crus cordis, which is where the AV groove meets the posterior interventricular sulcus, and here it branches into the PDA or posterior descending artery and posterior lateral. Both of these arteries, the PDA and the PL, are the ones responsible for the dominance of the heart, the coronary dominance. Dominance is synonymous with those arteries, the artery or the side that is in charge of supplying this the posterior interventricular section of the heart, which is mainly due to these two branches, PDA and posterior lateral, given off in 80% of the cases by the right coronary artery. The other 20% is divided in equal proportions, 10% left dominant and 10% balanced codominance. Why are there two arrows? Because one of these two arteries will be in balanced codominance, will be given off by the left coronary, and the other will be given off by the right coronary. Here you can see the different dominance patterns. The most common, the right dominance, 80%. That's why the PDA and PL are going out of this one. Remember that in LAO, the right coronary looks like a C. Indeed, it does look like a C. And then you have the codominant and left dominance. This classification 20.6 of coronary segments for syntax score is, I tried to simplify it by using a straight line. Then if you put the coronary artery in a straight line, you can divide them by this method. Then the left main is from the ostium of the left coronary until the bifurcation into the LAD and left circumflex. It's usually around 1 to 1.5 centimeters. Now, how can you divide the left anterior descending? Okay, there's important points here. The left anterior descending has 3 segments. The right coronary artery has 3 segments. The only one that has 2 segments is the circumflex. Okay, now the left anterior descending, how can we divide it? Look at the straight line. It is divided where the first septal branch goes, or where you find the first septal branch. If you divide the artery, meaning that anything that is first septal branch and proximal is the proximal segment. And from the first septal branch, you go till the last, to the final part of this artery and divide it from septal to the final portion, or final point where you see the artery. Divide this in 2 equidistant sections. That's why you can see X and X. And that will differentiate what is mid LAD and what is distal LAD. Okay, how can you divide the circumflex? The circumflex go to the first obtuse marginal branch, and that divides your circumflex in proximal to distal. Then how to divide the right coronary artery? Go from the first, where it goes out of the right coronary sinus, and let's see, it says the proximal is from the ostium to 1/2 the distance to the acute margin of the heart. Okay, then the acute margin is where you can see a pretty acute angle, and that's where you divide it from in general. So from the start of the right coronary to the acute margin, that's where you have your proximal and medial segment of the right coronary. How can you determine which is which? Just cut that section in half, and everything that is after the acute margin is distal. And dominance we already talked about, posterior descendant and posterior lateral branches. Okay, then incidence of coronary anomalies in angiograms. 1 to 5% of angiograms have an anomaly. It is the second most common cause of death in young adults. Most common of the anomalies in general are a split right coronary artery. They are not that, well, they are somewhat frequent, but not all are symptomatic. Then in table 20.2, you'll see that most don't hurt, but when they hurt, they produce angina. The mechanism with which they could produce sudden cardiac death is when there's aortic or pulmonary dilation, which affects the coronary anomaly, which may produce a distension, or may produce an altered affecting the position in general. So also aortic wall course or interatrial may lead to compression. Typical ischemia is usually seen in atresia arteries, or where they are severely stenosed, or in the context of Al Kappa, which is anomalous left coronary artery from pulmonary artery. And that's it for this summary. We're going on to next summary, part 6.